So Dr. Elizabeth Reed, Dr. Laura Tenner, and Molly Thomas, nurse practitioner, are here with us. We're going to basically give you guys as many questions as we can, and then we have several patients who will be joining us as well. So I am going to consult my list, and we're going to start with a heavy question for Dr. Reed and an important one as well. Dr. Reed, if you could go back and tell your cancer patients one thing that you know now, what would it be?
I would tell them to participate in trials, because now, as I look back, when I think about the trials we have offered in breast cancer, at least, I bet 90% of the new therapy that was being tested turned out to be the next best therapy. And so to have at least a 50% chance or greater to get the next best therapy, the way to do that is to participate in trials. And in the past, I used to hear physicians say, well, I know this is bad news, but in a few years things will be better, and you have that hope. And I used to not say that to patients because I didn't feel confident that that was true. And in the first 20 years of my career, it really wasn't true. But now, with 50 new drugs in the last year and all the progress that we're making, I do offer that as hope. So my message continues to be hopeful, and to maximize your chances for the next best therapy is to think about participating in trials.
Molly, next question is coming up for you, as we have a lot of healthcare providers who are who are participating in the conference today as well. What can providers do to support patients through and following the treatment course?
My answer to that is several-fold. I would say ask more questions about sleep, about mental health, about sexual function. So bring it up early. I know that we feel that patients are overwhelmed in the beginning with options, which they certainly are. But as a provider who sees patients after treatment, I hear on a very regular basis, I wish somebody would have asked me this or told me this resource before. So questions like, are you having trouble falling asleep, staying asleep, waking up too early? Are you having feelings of nervousness, tenseness, irritability, fear of recurrence? That's how I ask about mental health, asking those types of questions earlier and hooking them up with supportive care resources.
Questions are welcome from those of you who are participating. We do have a list from past evaluations that have come in that I'm going to kind of run down first. But if we've got time, we'll hit the ones that are in the Q&A as well. So go ahead and keep submitting those. Dr. Tenner, we're going to move on to you. Where do you see gaps in the care and understanding of cancer treatment?
Yeah, I really like this question because I think that there is a lot of misinformation out there. So I would just caution everybody on your internet searches and make sure that you involve your care team heavily on the things that you find on the internet and bring those to your care team so that they can clarify things. Some, I think, safe things are looking at guidelines from major cancer organizations. So the American Cancer Society, American Society of Clinical Oncology, finding guidelines there, that's the best way to do it. When you kind of go down the rabbit hole of the Google search, you may find things that are not exactly true. And so you want to make sure you take all that with a grain of salt, or don't go down the Google search. Just try and stick to those organizations with guidelines out there with specific patient information.
Dr. Reed, a lot of patients, they wait and they've got appointment time, and then the time that they have with their provider can be limited. But when they finally get that time, how can they make the most of it?
Well, I always tell people to keep a little pad of paper by their bed, because it's those 2 a.m. Thoughts that we should address. And so jot them down and bring your list, and we'll go through your list. I think it's also very helpful to bring your medications in. So I don't they're describing the color of the pill or the size, and I don't quite know what they're talking about, and I just think it'll be much more clear communication if they bring in their pills, we go through their medication, figure out which one's causing the problem or which one's helping the best, or even which one needs refilled, because sometimes that's not always so clear. And then I think the last thing is sometimes it's helpful if they just bring another set of ears, so that if they're under stress and they're not always taking things in, the things that I say, if they have a friend who's taking notes or listening or a partner, then what we've said, actually they go back and review and remember, and then that makes the appointment time more effective. So those would be the recommendations I have.
I think I'm guilty of telling my doctor before, it's that one that starts with a P,
Yeah.
because I can't pronounce it. So I can see how that would be helpful. Molly, we have a lot of survivors in attendance today. And one of the questions that we have is, what as a survivor can I do to give back and help others?
Great question. I would say get involved with your local group. You heard about Project Pinked earlier. Leukemia Lymphoma Society Omaha is another great one. A Time to Heal. All excellent options. You can attend our survivorship support group here and provide support that way. Maybe you had neuropathy and someone else just recently got the oxaliplatin and now has neuropathy, and you can share what you've worked. And a lot of patients I have tell me, oh, a large group setting is not my thing, but some organizations will help hook you up one-on-one with a patient that's the same age and stage as you, so you can kind of connect that way as well. So you could volunteer in that type of regard as well.
I know we have a survivorship group that meets virtually. What are the benefits of somebody getting involved in a group like that?
I think finding out that you're not alone in feeling nervous or feeling isolated during COVID, during cancer treatment, that maybe you're not alone in feeling, having the neuropathy or some of the sexual side effects, some of the things that maybe don't get always brought up in the office, or these type of things. I think you can find some support from someone who's been there.
Yeah, and if I could just briefly piggyback on what Molly's saying, we also have a fund that anyone can donate to that supports cancer survivors. And you can actually donate on behalf of a cancer survivor or you can donate anonymously for yourself. If you donate on behalf of someone, then a letter will be sent to that individual letting them know that you donated on their behalf. And that money will go to helping cancer survivors at the Buffett Cancer Center and also moving forward with survivorship research. So it's also another good way.
Dr. Tenner, since you were just talking, I'm going to go ahead and go to you next. Can you describe how palliative care teams are benefiting patients, and are palliative care teams being utilized in outpatient settings?
Yes, and yes. So first of all, I would like to make sure that everybody knows palliative care is not the same thing as hospice. Okay. Palliative care, or now sometimes called supportive care clinics, are clinics and providers and provider teams that specialize in the treatment of symptoms that come from cancer diagnosis and cancer therapies or cancer treatments. They also can help in the survivorship realm as well, especially for people who have a lot of side effects or toxicities from their therapies, including things like neuropathy or heart toxicity, cardiotoxicity. So they are definitely very helpful in that setting, even in people who are treated for cure in the survivorship setting. So when you hear palliative care, please don't panic. All that is saying is that we're going to help your symptoms, okay, that are coming from either the cancer or from the cancer treatments. And we do have them both on the inpatient setting, and it had been more traditionally an inpatient setting, but across the United States and really across the world, we're moving to more of an outpatient setting for palliative care, because we're finding that we can be more effective when we have people come in on routine basis to make sure that we're managing and controlling those symptoms appropriately. We find not only do they do better overall, but there's better better quality of life, less readmissions to hospitals and emergency rooms and those kind of things. So they're a very important part of what we do every day. And even in the survivorship setting, they can be very important. So it's important that everybody knows palliative care teams are on your side. It's very different from hospice. Don't panic if you hear it, and can be used very much in the outpatient setting to help you get through not only your cancer diagnosis, but through maybe some of the side effects you may carry on into survivorship.
Thank you. And the link that Dr. Tenner just mentioned, Courtney just dropped that in the chat. So if you are looking for that, it will be there for you to access. And it also is coming up on the slides in between as well. Dr. Reed, is there any research on lower dose tamoxifen for breast cancer DCIS? What if you don't tolerate the regular dose?
There is some research. You know, in breast cancer, our research involves thousands and thousands and thousands of patients. And so the traditional dose of 20 milligrams for prevention rests on those studies that have thousands and thousands of patients in them. But there are smaller trials with hundreds of patients that show that there is still benefit for prevention of new breast cancer. And that's what the purpose of the tamoxifen is for DCIS, is preventing a new breast cancer. It shows that a lower dose, sometimes 10 milligrams, 5 milligrams, or even they used a dose of 5 milligrams every other day, had some benefit in helping to prevent a new breast cancer. And that's usually for a period of 5 years. So if you're not tolerating tamoxifen alone, I always say, I think a lower dose, particularly if it can be tolerated, is going to be much better than nothing. And so it's something to think about and try.
Well, I've got you, Dr. Reed. A submitted question. Is it really necessary to be on the hormone suppression drug for a full 5 years? And do the side effects go away once you're off them?
So if they're I don't know exactly what we're talking about, but if we're talking about ovarian suppression, where we turn the ovaries off with an injection, and then you also take another endocrine therapy, either tamoxifen or the postmenopausal drug, an aromatase inhibitor. What we have studied is 5 years, and that 5 years really goes back to studies in tamoxifen years ago, where 3 years were clearly inferior to 5 years. So 5 years has always been our starting point, and we have extended beyond 5 years to 10 years in some cases. When we combine ovarian suppression plus another drug in the premenopausal woman, then that treatment is only for 5 years. And that's one of the advantages of combining. And yes, some of the symptoms can wane, particularly hot flashes and things over the first 6 months. If at the end of this treatment, you are still premenopausal, when you stop the ovarian suppression, all of those symptoms, those postmenopausal symptoms you had from that, should go away. However, if you, in the meantime, have stopped ovarian function on your own, then you'll still have some postmenopausal symptoms. So most of the symptoms will go away once you stop the drugs, particularly the AI drugs. They should go away. But if you've had some bone loss on the drugs, you're not going to magically regain that bone loss. So the answer is yes and no for that question.
Thank you, Dr. Reed.
As I answer all my questions, yes.
I think any of you could probably take on this next question, so I'll just go ahead and throw it out there, and whoever wants to chime in can. One of the healthcare providers has said, I work in a more rural cancer center where a large amount of the patient population is distrustful of doctors and or science. Do you have any suggestions for helping patients like this to work with their healthcare team and become more actively involved in their care?
Yeah, I can start, I guess, on this one. I think that's such a great question, because I think that kind of is starting to be somewhat more common for a lot of us physicians when we meet our patients coming in. There's a lot of information out there that kind of, I think, turns the tide against medical professionals. One of the things that I try and stress with the patients is that I'm on their side, I'm on their team, and that I want to work with them in the ways they, there is autonomy to the care that we're giving. So I'm going to tell them what the best data is out there, what the best recommendations are, and then we can work together to kind of find a middle ground for them and what their thinking is and what they'd like to try. I do know that sometimes patients need to try a few things that they found on Google and fail those before they're willing to try some medical treatments. But as long as you build that relationship with them, I think that they will most eventually come back around to those discussions about some evidence-based medicine and trials. But it is a little bit more of a difficult arena to kind of maneuver through. As much as you can utilize some of the things that the American Society of Clinical Oncology puts out there for patient information, make those things as accessible as those Google referral, the Google searches are, right? We want to try and get the information out there that is evidence-based as much as possible, that's patient-friendly and patient-focused. So within your cancer center, trying to make that available and trying to make patients aware of those things so that they're looking at those kind of websites, at those kind of materials, that's important as well. So those would be my suggestions.
To piggyback on that, I tell patients specifically when you're looking online, look for .edu, .gov, and .org. These websites rather than .com. We know are held to higher evidence-based standards.
Molly, well, I've got you. Obviously, treatment is a very active and specific phase of the lives of someone going through cancer. Once they have progressed to that survivor stage, what resources are available or what advice do you have to help them kind of make that transition from being in active treatment to being a survivor?
Great question. So I'll start by saying that the technical definition of a cancer survivor is the day we get that positive biopsy result and the day of diagnosis. And so, we can kind of start these conversations of what supportive care resources are available earlier. That being said, I do completely understand and hear all the time. It feels very comfortable for me to see my doctor and my treatment team every week or every day or every other day. And then all of a sudden I hear, okay, your scan looks good and we'll see you in 3 months. And that can make someone feel very fearful. And so once you're getting towards the end of maybe radiation or chemotherapy or these type of things, certainly surrounding yourself with a support group and loved ones are wonderful, but maybe also to some of these community groups or others. Thinking about a program such as A Time to Heal is wonderful. It's free, and then focusing on this mind, body, soul approach to healing. The Cancer Project Pain for breast specifically, Leukemia Lymphoma Society, kind of surrounding yourself with a group before the end. And ask for a survivorship visit as well. Self-refer yourself too. We're happy to help you. And we get an hour with our patients. So happy to give you some more specific suggestions.
Thank you. Dr. Reed, it would be wonderful if you could tell every single one of your patients that you caught the cancer early and it's highly treatable. As we know, that's not the case. And some people get diagnoses that are aggressive cancers, or they might have a poor prognosis. So what advice do you have for someone who has a loved one who has this kind of situation, how they can help boost their morale and support them?
I think open communication is probably the best thing. So, when you say an aggressive cancer or poor prognosis, I think that in breast cancer, at least, we have aggressive cancers that are caught in stage 1, 2, or 3 that in the past have had a poor prognosis. But with the therapy that we have, that's the purpose of the treatment. It changes it into a curable situation. If you're talking about metastatic disease, where the goal is to make the patient feel better and hopefully live longer, but cure is not the realistic goal, then I think being very understanding of what that goal is and also to just communicate with the patient that what their goals are is what's important. So many times patients are continuing with therapy or doing things they don't want to do because they think they'll be letting their family down if they don't do them. And the family is thinking that they don't know how much more their loved one can take care of this, but they don't want to say anything because then they're not supportive. So I just really think open communication about what people are really feeling, and then working through that, and how you're going to incorporate that in the treatment plan with your physician. And the physician needs to be part of that communication so that they really can, if they want to continue with therapy that will meet the goals of the patient, and that the family understands that that's why that therapy was chosen with those goals in mind. So I think it's really that working on open communication. And I think it's a hard job, and that's why I think palliative care is so important, because they really do help promote that communication.
Kayla, if I could interrupt just briefly, there was a question that Rachel was quick to move over into the panel, but I want to make sure that everybody hears about it because I think it's an important question. And this is about pancreatic cancer treatments, which everybody knows to be a pretty aggressive cancer and has somewhat limited treatment options. Being one of the GI medical oncologists at the Buffett Cancer Center, I would like to highlight the fact that we do now have a dedicated Pancreatic Cancer Center of Excellence, which has substantial clinical trials moving forward. And so I would invite anybody to make sure they check out our clinical trial options, things like that, in terms of pancreatic cancer treatments and discovering new things in the future. There are some exciting things coming down the pike in terms of KRAS mutated driven treatments, as well as other things for pancreatic cancer. And the more people we can get on these clinical trials, the faster we can get things to the bedside. The other thing I would like to mention is we also have a trial for high risk. So if you have a history of pancreatic cancer in your family and are high risk, please look us up and call us up and see if we can enroll you into some of those clinical trials as well. So a lot of exciting things coming down the pike for pancreatic cancer. Thank you for that question.
I think obviously one of the things that we want to emphasize here in this conference today is the importance of research and the importance of those clinical trials. So that's something we're going to continue to highlight. We need to wrap up our provider panel and go ahead and roll into our patient panel. So thank you to everyone who submitted questions. We are going to go ahead and make the transition to our patient panel as well. Dr. Reed, Dr. Tenner, and Molly, thank you so much for your time and your expertise. So